So right now what I'm gonna do is I'm gonna vent him. So because Arden is fed through his Gtube, and he has something called a fundoplication, which basically ties the top of the stomach, he can't burp himself. So he was fed about a half an hour ago, and what you have to do is, because he can't burp, is essentially we vent his tummy, which is what I'm doing right now, and that is like burping him. So we take the syringe, we attach it to his Gtube extension, and
to see if he has any air in his tummy.
Because just like any baby, if he gets a lot of air in his tummy, it can upset him.
So does it, when you do that, does it also, it takes what was in his stomach as well a little bit?
It does, yeah. So then we have to reinsert like his stomach contents.
Okay. So then we push this, we take the air out and we push all the feed back in. And then after we're done, we always flush it with sterile water.
Just to flush the line out.
Yeah, just so that the line doesn't have stale feed in it. And then once we're done that, we can actually take it off his little Mickey here.
Yeah.
And a little droplet usually comes out, but dry it off.
So that's essentially just a little Gtube peg that just goes straight into his stomach.
Goes right into his belly.
It has a balloon inside that's inflated to keep it in place, and then that's how he gets fed, gets all his meds, all that. Hey, bud. Yeah, so this is Arden's ventilator, and everything on this cart is kind of everything that he needs for a day, and we put it on this cart because then we can take it to whatever room we need to take it to. So the vent is what ensures that he gets the pressure that he needs maintained in his lungs. So he has specific settings. He is on a PEEP of 19 and a PIP of 9. And essentially the PIP is what inflates his lungs when he breathes in, and then the PEEP is what is maintained in his lungs when he exhales, so that his lungs don't just collapse. Because he does have a restrictive lung condition. So, and then that's tied into his concentrator, which provides about 1 liter per minute of oxygen, which is probably about 23 to 24% oxygen, and what we breathe, like room air, is 21%. So he just gets a little bit more than what we need. And then we have his suction and his feed pump.
So the vent connects to the humidifier pot. So what this does is it heats the water in here, and as it blows the air that's going to go to his lungs, it humidifies it. Because he doesn't breathe through his nose, it goes directly into his trachea. We have to humidify air so that essentially the secretions that our lungs naturally produce don't dry out, become very thick, and then they become very hard to mobilize. So what this does is it essentially acts as an artificial nose.
Yeah. Yeah, so then we always have him hooked up to an oximeter, which tells us his oxygen saturation percentage as well as his heart rate. So we always want, like right now he's 97% oxygen saturated, which is great. We want him at least above 90%, and that just tells us that he's getting the oxygen that he needs, that his ventilator is working properly. And then we also monitor his heart rate as well. Arden has had ectopic atrial tachycardia since he was about 2 weeks old. And he's on a med called propranolol that manages that, but he's been doing really well with that. And we haven't seen a lot of tachycardia lately, so we're thinking he may be able to come off that med soon, which is great.
And what is tachycardia again?
Fast, an unusually fast heart rate. So essentially anytime somebody's tachycardic, it's when your heart rate goes faster than it normally should.
So what I'm going to do now is suction him. So I don't know if you could hear it, but he just coughed, and you can kind of hear like a rattly secretion. So what we do, we sanitize our hands. This is a suction catheter, so We'll show you a little more in detail just with a test one that we have, what I'm doing, but essentially there's numbers on the side of this and it's a very specific measurement. So his measurement is 12, so we always have to go 12 centimeters in from the tip of his trach. So we turned on the suction machine, pop off his vent.
Take this. Excuse me.
Go in through here. So we're at 12 centimeters. Spin it, pull it out, and pop it back on. And then with this, you always sanitize it in a saline solution just to prevent bacteria buildup.
Yeah. So that can happen anywhere from once every half hour to like once every 5 to 10 minutes.
Hi.
So each time you pop that ventilator off to do that, is he essentially like not really getting much air, the amount? Or
Yeah, he
Yeah.
essentially has to breathe on his own at that time. So in order to be able to do that, we actually had to do tests of this in the hospital to make sure that he was able to come off his vent to do open suction, they call it. Yeah. So he,
So
has
he
to be
can
stable
breathe
enough.
on his own for the first few months after he was extubated, I guess, or not, about a month after. We had him on different machines, like BiPAP and CPAP machines.
Yeah.
And he was able to do that. It just, he had to work so hard to breathe
Yeah.
that he wasn't distributing kind of resources elsewhere in his body to help him grow and develop.
Yeah.
So that's why we decided this. So, I mean, going back, when we do pop it off, he is able to breathe. When we do put the suction catheter in and suction it, essentially we are taking his breath away. So you want to try and do it in under 5 seconds if
Yeah.
possible.
As quickly as you can, really, while still getting the job done.
Yeah.
Yeah.
Hey, what do you think? Should we get your trach care done? Like, I don't know. I'm not ready to perform today.
No, I'm ready for a nap.
Hey, should we get your trach care? Okay, well, let's.
Ready?
This is gonna make you a little roll. Ready? All right. Let's get you cleaned out for the day.
You betcha.
So I have like all of his stuff for like trach care, and well, we call it beauty care, but that's essentially just his face stuff, but organized into little bags. That way we can do it in any room we need to, because it just needs to be convenient for us. Yeah. So we'll just clean up his, every morning we just clean up his Gtube area, and we clean up, make sure his trach is clean and sanitary, just so that we are making sure that he doesn't have any bacteria growth or anything like that happening. So yeah, we do that twice a day, in the morning and at nighttime. And then, yeah. So, what we'll
So
do,
this, I'll just go and get a couple things just so that we can show exactly what everything is.
Say hi. Hi.
He has 7 so far. It's crazy. We had a rough couple weeks ago. It was a rough go. Yeah.
like all first started really coming in?
Yeah. Well, and because he's Arden, when he gets more, like, kids drool when they're teething, and because he was getting more and more secretions, his oxygen requirements were going up, and we were getting worried because he was not satting as well as he normally does oxygen-wise, and it was really all just because he was teething. But for him, everything seems so much more. Yeah.
So his Gtube, like I say, there's essentially a direct pathway from his skin or his belly into his stomach. And what it is it's this little device here. So obviously this is the outside and this is the inside, and what this is it's a cuff, and what that cuff does is you fill it with water, and if you blow it up, And essentially, when that sits in his belly, it creates a seal and it prevents it from pulling out.
That's an old Gtube. So
yeah, this
it's
is
dirty and old, but
it's a good training
good
one.
representation. Yeah, we keep it to train our caregivers so that they can see how things work for Arden internally.
Yeah. Hey, buddy. Hey, mister.
Okay. So essentially what we do for trach care is I just prepared 4 Q-tips that are wet with saline and then 4 just left dry. So we do like a 4-quadrant system, I guess you could call it, because you don't want to put any bacteria into the trach area that isn't already there. So when we do this, we'll take out his dressing and then we'll do a wet saline Q-tip in each of the 4 quadrants kind of his stoma, and then we'll do the same with the dry Q-tips and then put in a new dressing. And the dressings that he has on are antimicrobial dressings so that we avoid the growth of bacteria and that kind of thing too.
Hi. Are you ready? Mommy's gonna take your dressing out, okay? Yeah. You're such a good boy, you know that? Mm-hmm. Yeah, you're such a good boy. Yeah. Mm-hmm. Oh. You need a section? Yeah. I know. Okay, we'll pause. We'll pause. Okay. Good boy.
It's his mouth too.
Yeah.
Okay, honey. Okay, Mommy's gonna turn you over because you have a lot of stuff in your mouth. Yeah. Hello. No helping.
There
Gotta
we go,
let Daddy
little
get
boy.
it. Good boy. Okay.
Was it thick in his drink?
Mm-hmm.
Maybe give him an instill. He's still getting coffee kind of.
Hey, sweetie, it's okay.
So what we're gonna do here is we're gonna do something called an instill. So when his secretions get really thick, we just put a little bit of water into.
It's normal saline.
Yeah. Just a couple drops.
We just let a few breaths go in, and that essentially breaks up the secretions so that we can suction them out.
Okay, baby. Okay. Good boy.
He's got more in his mouth, I think, hon. It's okay.
You okay?
There we go, little boy.
I'm going, sweetheart.
Yeah.
Yep.
Okay, good boy. Good job, little Arden. Good job. Hey, good job.
So with that, because he needed a big suction episode, he actually desatted a little bit. So that's his oximeter ringing off, saying that he's not getting the oxygen saturation that he needs right now. He usually quickly comes up from that for the most part, but because he had his breath taken away a lot there, he desaturated a little bit.
How often does something like that happen? Like when he does need a big suction like that? Like is that a couple times a day
Yeah,
occurrence?
I would say probably at least 5 times a day that'll happen where he needs a big suction like that. And then other than outside of that, then he just needs regular suctions. Like I say, it can be anywhere from every half hour to like every 5 to 10 minutes, depending on how he's feeling, really.
Okay, buddy. Yeah. Okay, you ready? You're gonna clean your stoma. There you go. Yeah.
You're such a good boy.
You're such a good boy.
So essentially, you kind of want to go like into the stoma first and then pull outward to get anything that's in there coming out. Oh, honey needs another suction. And so weekends are really great because I get to have help with all this stuff. So Arden likes to sleep in. So lots of the time when it's during the week and Brody has to go to work, I just do all this stuff by myself.
Hi, good boy. Okay, excuse me.
Hey, good job, little boy.
Yeah.
Good job, buddy. Yeah.
He's feeling pretty good about this right now because his stoma is actually is looking pretty great. A couple weeks ago he got a little bit of irritation, I guess, on his stoma, and it was really sore for him, so he would cry when we did trach care, which was not nice.
It's feeling pretty good now, isn't it? Yeah. Okay.
You get a new Gtube pad too. Oh, you got one?
Dad picked this one for you. You can have this one. Yeah.
So actually, one of the ladies in town here,
Erin,
yeah, made us these Gtube pads, which was really great because those just make it so that if he does have any leakage around his stoma, then it doesn't get wet and cause bacteria growth or, that kind of thing.
Yeah.
And one question we actually had that we never knew about with the Gtube is because it's essentially an open hole from the environment into his stomach, is we thought, can he have a bath,
Yeah.
right? Can he be submerged in water, or do you have to keep the water level away from that? But what actually happens is because your abdomen and your stomach has more pressure than the outside, is it would never actually leak water inwards. It always pushes stuff out. So
Yeah.
you can completely submerge him, other than his trach, obviously. But in terms of the Gtube, you can put. He loves his baths. He has a lot of fun.
I just got to get a cloth on.
So now Mom's just gonna go and get some cloths, or a cloth, so that we can clean his face and do his beauty care. Yeah, you are a cute little boy, aren't you? Huh? Yes, you are. Oh. Hey, buddy. What's this?
Well, and a lot of like getting a trach and getting a Gtube and all that stuff was like, okay, we need to ask questions about what can he do? Can he go outside? Can he take a bath? Can he, how will things look?
Right? Yeah. Yeah. Oh, so cute. Okay, Dad needs to hold that because I need to wash your hands, all right? Yeah. You get your hands clean for the day. Okay,
All right.
put that away and then Mom will get your toothbrush.
So this little guy has a very sensitive skin in terms of developing like eczema and rashes. So every day and night we put on his
We do his beauty care.
beauty care, yeah,
That's
his
what we call it,
eczema
yeah.
cream.
When he was in the hospital too, when he was really little, and he didn't, even when he was partially sedated and that kind of thing, I would give him like little face massages with his moisturizer, and he loved it.
Yeah.
And they taped him so much.
We're gonna brush your teeth. Okay? You're gonna brush your teeth.
He doesn't like this so much yet.
We're getting used to the whole toothbrushing business.
Oh, I know. Oh, it's okay. Okay, let's do your bottom teeth. I know, you gotta let Mommy in there.
We're actually just getting to the point now where we can put things in Arden's mouth, because up until the point that he was finally extubated in July, he had an endotracheal tube in his mouth and his throat. So he really grew an aversion to having things put in his mouth. So, and then just with having to have oral suctioning and stuff like that, a lot of the experiences that he had when he was really little were negative whenever he had to have things put in his mouth. So now he's starting to chew on things on his own a little bit, letting us put his toothbrush in his mouth.
Jen?
Yeah.
Ooh, get your chapstick. Oh, yes,
His chapstick he usually just likes to lick off.
Yep.
What do you think? What do you think, mister? All done. You're all good. You're clean for the day. You're fresh. Can we have that back? Can we put it away?
Thank you.
Can I just put that in that bag too?
Yeah.
Thanks.
There you go. What do you think? What should we do? What should we do? Huh? Huh? What do you think, mister? Huh? What do you think? Do you want to sit in your chair? Huh? You want to sit in your chair?
He's like, what's happening here? So we got this tumble form chair is what it's called from occupational therapy in Grand Prairie, which is great because it provides more support for his body. So Arden does have scoliosis, and because of the way his body is with his muscle and joint contractures, and because of the fact that he was having to be in his bed for so long when he was younger, intubated, he's not able to sit up on his own yet, unsupported. So we have like a bumbo chair for him, but it just doesn't provide enough support for his spine. So he'll often tip over to the right, which is the way that his spine curves with his scoliosis. So this helps to just provide a little bit more support for him. And you can sit up and have some fun. Yeah, you can. And we do developmental activities every day to try and grow his strength and grow your abilities.
Yeah, we do.
So we work with physical therapy and occupational therapy and the orthopedic teams and stuff like that to come up with plans to further his development.
So we also use rolls just to position him a little bit better, in the sense of trying to position him against the curve of his scoliosis so that he has to work against it, just to prevent any progression.
Yeah. We actually just recently, he had x-rays, because they do x-rays about every 3 months on his spine just to see if his scoliosis is progressing. And we did get x-rays done, and they're very, I don't know, you could say that they're hard, it's hard to guess, or not guess, I guess, measure the degree of a baby's scoliosis, because I could be positioning in the x-ray and that kind of thing. So they suggested that his scoliosis had gotten to a 44-degree curve, which would be quite severe. And then when we visited our pediatrician, he suggested that it doesn't look that severe at all, that it was probably closer to a 24-degree curve than a 44-degree. So that's good news, really.
I think the last one that we had in the hospital, I think he was 28 or 29, is what they figured.
Yeah, there's been a few. It depends on the radiologist that's reading it, the doctor that's looking at it, what they'll
and
measure it at.
it also depends too on how you hold him. Like his spine is stiff in terms of your everyday baby that's 10 months old, but his scoliosis, you're generally able to get him to what we would call neutral, so his spine is essentially straight. You can get him very close to that. So essentially, if I positioned him and had him x-rayed and I held that could take just about all the curve out. But if you just set him on the table and let him wiggle around, lots of times he likes turning to that right side to look at things, so it'll actually functionally look like a higher curve.
Yeah.
So there's a lot of variables in how you measure it and how it progresses, but based on what we're seeing from day one till now is he's made huge leaps.
Yeah.
He's moving in the right direction. Like, it'll be something that that challenges him throughout his whole life.
Yeah.
But to what degree is
Yeah.
we don't have those answers yet.
No.
Ooh.
Yeah. Yeah.
There we
Oh,
go.
good
Oh,
boy.
yeah.
Good boy. Yeah, good job.
Give me 5.
You have 5? Oh,
Yeah.
yeah. Nice. Can I have a 5? No?
He's like, no. It's Saturday for
Give
the
me
boys.
a 5.
Just the
me a
boys
5.
get 5s. It's crazy.
Your hair is crazy. It just does what it wants, doesn't it? Kind of like you.
Mm-hmm.
You just dance to the beat of your own drum, too.
You're so interested, aren't you?
So curious.
Want to bounce?
Maybe a bouncy baby? A bouncy baby?
Docile this morning.
Yeah. You little sleepy.
So the cognitive side of things and mental development, he should. We don't have any concerns regarding that.
Really,
He did have what was it, mega foreman?
He has a megacisterna magna, which is actually just a larger, in the fluid space behind the cerebellum in your brain. His is a little bit larger than is typical. So they were worried about that before he was born. On ultrasound and MRI, they noticed that, but it hasn't become a factor, and they don't think that it points to any other, I guess, symptoms or conditions or anything like that. Really, as far as how he interacts, how he tracks, you know, all of those things that you look for as babies are developing, he's showed very typical milestones cognitively and emotionally and socially. So that hasn't really been a concern at all, which is, you know,
Which is a relief for us.
I mean, the only real, you know, deficits as far as how he interacts with people is his physical, you know, deficits, I guess you could say that.
Yeah. Yeah.
Like, I mean, for the longest time, even he didn't learn how to smile because we had to, you know, COVID protocols were in full effect at the hospital, and we were in the NICU with shared rooms with other families, so we weren't even allowed to take down our mask. So he never saw our faces until we got,
You need a section.
really until we got our own private room in the PICU, and then Brody and I were able to take down our masks around him, and he could see what our smiles were like and start to learn some of those facial expressions. Fighting me, he's trying to like,
You're trying
Needs
to
his mouth done too.
you're trying to push yourself off of Mommy's lap. Yeah. There you go.
yeah.
Here. Yeah. Yeah. Yeah.
Yeah, so that's one thing that's been really good for him is just social interaction since we've got home. Rael and I obviously don't wear masks in the house, so that he can kind of get that development and that recognize different facial expressions and what they represent.
Yeah.
So we're really noticing lately that he looks to one of us for approval, or you know, if he thinks something's funny, he'll look at Mom or I to see how we're reacting, to see how he should be reacting.
Yeah,
So
which is totally
that's-
appropriate for babies to do that. And I mean, that was difficult for a few months in the hospital when we weren't allowed to take down our masks and he wasn't allowed to see our facial expressions.
No, you weren't able. No. Yeah. Mm-hmm. Yeah, yeah. Yeah.
And even just the limitations that he had, you know, in hospital, you really can only play so much.
So one thing you'll notice, the compensation strategy that he has developed.
Is it scratchy? You itchy?
So he has something called ptosis, and that's a drooping of the eyelids.
No, he doesn't.
So most of what people have seen in his pictures is usually his head is back, mouth open, but that's how he actually looks up, because the drooping of his eyelids limit his ability to see anything above him. So what he does is he puts his head back, and that gives him the ability to kind of look up at our faces.
Yeah, and that's just another one of those with Escobar syndrome. That's a lot of kids that have Escobar syndrome will have ptosis like that. So just another kind of common feature, I guess. Yeah.
What do you want to do? Do you want to go in your bouncy seat?
Oh, that
Do you want to bounce?
Do you want to bounce? I think you should.
Would you move this and bring it
Yeah.
over?
Do you want to bounce?
We're in his car.
Hey, man.
You're gonna have to move, or else we'll have to move his ventilator.
Whoa, what's that?
Okay, I'm gonna unhook your. Don't press pause on his. I just can't reach behind me.
On his what?
Oximeter.
Yep.
Because I'm gonna unhook it so we can get you in here.
Okay. Alrighty. Daddy, I'll get your feet in.
Yeah. Whoa. So he's getting stronger, actually, where he can hold himself up and things like this for a certain period of time, I would say. Whereas before he would instantly just bloop, kind of plop over and not be able to hold his, because he has low tone centrally, so his trunk control and his so his trunk control is limited, core strength is limited, but it is getting better. He is able to hold himself up some more. And then when he does get tired, we just provide extra support for him with blankets and rolls and, you know, just make sure that he's positioned in a way that supports his spine.
Up, little boy.
Wow! Can you bounce? Can you bounce?
So he hasn't, I mean, with the limited mobility in his legs, he hasn't quite figured out the bouncing thing too much, but he'll give a little bounce every once in a while, and he's started to move himself side to side, so he likes that.
He'll sway.
Yeah, he sways.
Yep. Good two-stepper.
Yeah?
So.
Can you bounce? Oh, Mr. Crab in there. Get him. Get him. Get him. Yeah. Can you get him?
Arden, Mommy's gonna bounce you. Ready? A bouncy, bouncy baby. A bouncy, bouncy baby. There you go. There you go.
Wow! What do you see? What do you see? Oh, you get him. Get that star. Get him. Yeah. Do a little support. There.
There, mister.
Can you push some more? Can you push some more?
You want those rings? Want those rings? What if I give you something else? Okay. Those ones. They're pretty groovy too. What do you think? Yeah. So, I guess you'll notice Arden's pretty quiet. He's actually with the trach that he has, it has a cuff on it. So just like that balloon that we showed you on his Gtube, he actually has a little balloon called a cuff that essentially occludes his airway fully so that he doesn't have air leak around the trach.
I brought the training one, so.
And so essentially what that does is it prevents air leak. It makes it so that the pressure that the ventilator's giving him is what he's getting, and he's not losing any of that pressure out of around the trach. But it also makes it so that he doesn't have any air passing upwards over the vocal cords. So with that, he doesn't produce any sound when his cuff is up. So that's...
So can you see this? So this is the trach essentially. This is the external component. And then his stoma is essentially the hole that we keep talking about. That's what Rael cleaned earlier today. So this tube goes through the stoma and into his trachea. And so the cuff that she's talking about is the little balloon, kind of like his Gtube that fits in here. And we put, again, sterile water in it. And we change this.
We'll just use air to show you.
We'll just use air, but we change this every day. So kind of like a suction machine, it's a very measured process. So we put 3.2 milliliters in the cuff, and that's what forms that perfect seal. So it blows up, and that sits tightly around his trachea so that when the air gets administered through it, it doesn't actually leak up through his vocal cords, through his mouth. And the secondary thing that it also does is it prevents anything from going down into his lungs. So any of the secretions that come from his mouth, so essentially he doesn't choke or he doesn't get any fluid buildup in his lungs.
Yeah.
So that's why it's so important to suction that too.
Yeah, because
does it clean like on the top side and the underside of the?
just the underside. So I'll go and grab a spare suction catheter and I'll show you.
Yeah, no, he definitely...
In school, in
Yeah,
physio
it's just
school, we actually had to do suctioning on each other in class, which was interesting. We would go through the nose, and the sensation is actually quite weird because you go down to a certain point and it's just a reflex that you have. You just start coughing. So that's kind of why he makes the faces. Essentially, it elicits that cough reflex. But so, like I was talking about earlier, is it's a specific measurement that we have to go in, because if we went down too far, we risk hitting the spot in the lungs where the trachea splits. And just the trauma of hitting that could essentially cause damage to the lining, cause bleeding, that kind of stuff. So
causes scarring in the airway.
Scarring in the airway, exactly. So the 12 centimeters on the tip of this, it's open, and then there's little holes on each side, 2 little holes. So when you hold the 12 centimeters and you put it in, it actually sticks out just to the bottom of that hole. And so that measurement, we know if we go to that point, it's not going to hit or the bottom where that split is. So those holes are where basically the suction machine pulls all his secretions from underneath up and out. Because when he coughs, the only way that those secretions can come out is through the end of this tube. So he'll cough it up to the bottom of it, but that constant air that's being pushed down, it kind of acts against it, and it's trying to push it back into the lungs. So that's why we have to stick this in and suction it out to clear that pathway.
Yeah.
And then, like, when he's pooping, obviously, but like you were talking about earlier, drooling, does that try and go past the little balloon?
It'll sit on top of it.
So it collects on the top of it, So every day when we change the cuff water, we have to be ready with the suction, because as soon as we take this down, it essentially leaks down into the top of his trachea. So once we fill it back up, then we suck all that out.
Yeah. And so when he gets all those secretions and it sits on top of his cuff, it still gags him. So that's, you know, those are secretions that are hard to get with his oral suction or with his deep suction.
Cute.
Tata, you don't need to play with that. No.
Here, let's tuck that in. You don't need to play with your cuff. No. No, you don't. No. What do you think? What do you think, mister? Yeah.
Huh? Yeah.
So he is, like, I mean, with facial expressions and that kind of thing, he is really good at showing us how he's feeling. But essentially, because I can't hear him, I have to be in the room with him all the time. So if he's napping or playing, you know, I have to have eyes on him as much as I possibly can, just so that I know that he's okay. I've kind of learned to, like, if he's sleeping and he sleeps in his room, I can be in the living room or kitchen, because I've learned to listen to his ventilator and how it sounds when he's sleeping, like how fast he breathes when he's sleeping versus when he's awake, or I can kind of hear the little crackles when he needs a suction, that kind of thing. So I can go a short distance away when he's sleeping, but otherwise I try to be near him most of the time, because I need to have eyes on him to know that he's okay. Unlike a typical baby, you'd hear them cry and you'd, you know that they needed something.
And he can't cry just because of the...
Yeah, and it's essentially, Arden can make sounds. Like when we first had him, I guess he was extubated a few times. But before he got his trach, he had like a little scuba BiPAP mask, which was horrendous, but it actually looked really cute. And so because he didn't have anything in his mouth and his throat, that kind of thing, he was starting to get his voice at that point. And he can make sounds, he can cough out loud, he can cry out loud. It's just because of that cuff in his trach that he can't. So he is capable of making sound, he just isn't able when that cuff is up. We used to hear him make little hiccups when he had his scuba BiPAP mask, and he'd go, oh, oh.
Can you put that back on for me?
Yeah. Yeah, mister. Yeah.
Stability-wise, he's done pretty good since we've been home.
Yeah.
Like
he really has good.
He's been happy, he's been thriving, he's grown a lot, like he's gained weight, he's grown in length, you know, which are all signs that he's doing well as far as his breathing, especially like when, you know, Brody says before we made the decision to get his trach, it was kind of our only option at that point, because he had that scuba BiPAP mask for about a month and we weren't able to de-escalate respiratory support at all. So he was sweaty a lot of the time, he was tachycardic, like his heart was beating too fast, he wasn't gaining weight, and essentially over time, those are all signs that, you know, his lungs were just working way too hard. And so essentially when we said yes to him getting a trach, we knew that he would have to have that in order to thrive. So it was
it was a scary decision.
It was. It's like your whole world changes, because you're like, okay, your kid's going to be hooked up to a ventilator for how long? We don't know. It could be a few years, could be the rest of his life. We don't know at this point.
No.
Yeah, it just depends how he grows and develops, and